Hello, everyone. I'm Lisa Anderson, the Project Director for eClinical in the Department of Quality Measurement at the Joint Commission. I would like to thank you for joining us for our Pioneers in Quality 2018-2019 Expert Series. Today, we will be focusing on the CAC-3 and EHDI-1a eCQMs. For participants that would like to use the closed captioning service, please see the link on this slide. This information is also accessible via a participant pane in the GoTo webcast platform. The Joint Commission and CMS designed the Pioneers in Quality Expert Series to support hospitals adopting electronic clinical quality measures and transitioning to the new Clinical Quality Language, or CQL. We introduced this series with a CQL Basics webinar, followed by sessions covering the stroke, AMI, ED, and VTE eCQMs. And based on participant feedback, we have extended the webinar sessions to 90 minutes to allow for a live Q&A session after each measure presentation. At the end of today's session, participants will be able to apply concepts learned about the new CQL expression language for CAC-3 and EHDI-1a, identify their common issues and questions, and prepare to implement CQL for the 2019 eCQM reporting year 2020 data submission. The slides are available in the Events Resources pane. Click the triangle to open the list. Once selected, you will be able to download and print the slides. These sessions are designed to be interactive. The questions pane will be open throughout the presentation to ask questions and view responses in real time. If possible, please indicate the slide number you are referencing in your question. Additionally, you can visit links or resources noted on the screens. Please note, a recording of today's presentation, the slide deck, and Q&A documents will be available on the Joint Commission website in several weeks. We hope you find this information helpful and share it with interested colleagues. The e-credits are offered for all our Pioneer in Quality webinars. This webinar is approved for 1 continuing education credit for Accreditation Council for Continuing Medical Education, American Nurses Credentialing Center, American College of Healthcare Executives, California Board of Registered Nursing, International Association for Continuing Education and Training, Certified Joint Commission Professionals Recertification Credit. CE, CME, CEU credits are available for the live audio only. Credits will not be available for webinar replays. To claim credit, you must have individually registered for the webinar, listened to the live webinar in its entirety. Only those listening live are eligible to receive credit. Completed a post-program evaluation. The program evaluation link will be sent to participants' emails after the webinar. Printable certificates will be emailed 2 weeks after the session. All participant CE certificates will be sent at the same time. If you are listening with colleagues and did not use your own link or phone line to join, you can still obtain CE credit. If you meet these 3 criteria, an automated email after the session will provide information on how to access the survey. For more information on the Joint Commission's continuing education policies, please visit the link provided at the bottom of this slide. The following staff and speakers have disclosed that neither they nor their spouses or partners have any financial arrangements or affiliations with corporate organizations that either provide educational grants to this program or may be referenced in this activity. Lisa Anderson, MSN, RNBC, Project Director, eClinical, Department of Quality Measurement. Marilyn Perenzin, MBA, RHIA, CPHQ, Associate Project Director, eClinical, Department of Quality Measurement. Elvira Ryan, MBA, BSN, RN, Associate Project Director, Department of Quality Measurement. Lynn Perrine, MSN, RN, Senior Nurse Informaticist, Lantana Consulting Group. And Jidong Deng, PhD, Centers for the Disease Control and Prevention. I am now going to turn it over to Elvira and Marilyn to begin their presentation.
Good morning, everyone. This is Elvira Ryan, and I'm the clinical lead for the chart-based Children's Asthma 3 measure. And by way of review, I'll just offer an overview of the clinical rationale and the intent of the measure. Asthma is the most common chronic disease in children and a major cause of morbidity and healthcare costs nationally. In 2015, almost 50% of the children with asthma, age 18 and younger, reported having an asthma attack within the last year. Chronic asthma in children accounts for a significant annual loss of school days and subsequent annual loss of work days on the part of their parents. The guidelines continue to support patient education for the self-management of asthma. With respect to the home management plan of care, there were 5 basic criteria that had to be met in order to satisfy this measure. The first criteria was that arrangements for follow-up care were made prior to the discharge of the patient from the inpatient admission. This meant that the patient should have an actual appointment scheduled prior to discharge. The reasoning being that more often than not, if there were no appointments made, chances are that the follow-up would not take place. With respect to the second criteria, environmental control and control of other triggers, it is key to note here that it is very important that this component of the management plan of care would be individualized to the patient. Environmental triggers in one setting might not be the same for a patient in another setting, so that the plan of care should address an individual patient's specific environment so that it would pay attention to their unique needs. The method and timing of rescue actions was a key component also of the plan of care, and that was to instruct the patients and their caregivers when it was appropriate to take action, what steps should be taken, and when, at a given time, the patient might have reached a critical stage where it was necessary to contact the physician. The last 2 criteria addressed the use of controllers and the use of relievers. If the patients were prescribed these medications while they were in the hospital, these needed to be addressed so that they were well aware of the names of the drugs, the dosing, and the timing for administration. I will now turn it over to Marilyn.
Thank you, Elvira. Good morning, everyone. This is Marilyn Perenzen. I am an eClinical Associate Project Director in the Department of Quality Measurement at the Joint Commission. Before we dive into the measure specifications, I want to take a few minutes to provide a framework for today's presentation. CQL, or Clinical Quality Language, is used to write the measure specifications. And the goal today isn't to teach you how to write CQL, but to help familiarize you to the CQL terminology so that you're better equipped to read and understand the specifications to support your organization. So we will be somewhat technical in nature throughout the presentation, but with eCQMs, the technical jargon impacts the clinical intent of a measure. So it is important to be acquainted with both aspects. And with that, let's get started with a high-level overview of some of the CQL basics to set the foundation. Slide 14 shows the evolution of the standards to create eCQMs. eCQMs consist of 3 components. First, we have the metadata, which uses the Health Quality Measure Format, HQMF, which is the basic electronic specification for the measure. Second, we have the data model. We use the Quality Data Model, or QDM for short, which defines the relationships between patients and clinical concepts in a standardized way. And lastly, we have the logic. So as of January 1st, 2019, we made the transition from QDM to CQL because it allows for more flexibility in the logic with better timing precision so that the logic can be better aligned with the clinical intent of a measure. Slide 15 shows a screenshot of a human-readable file. For those that are new to eCQMs, a human-readable is the file format of the measure specifications for a person to read versus a computer. And the first thing I want to point out is if you look under the initial population, it's only referring to a single line. For example, TJC.encounter with principal diagnosis and age. So this is a major difference from the QDM version where there were lines and lines of logic. With CQL, the logic is simplified into what we call definitions. And we title these definitions using more natural language to capture the meaning of the logic it represents. The second thing to note are the definitions and functions sections. I've bracketed these two sections together as building blocks because collectively, these are all the definitions used to build the population criteria referenced at the top of the page. So to give you a better understanding of the CQL structure, this diagram depicts a visual representation. If you can imagine that these blocks are like Legos, and if you've never played with Legos before, you're given a set of directions that instruct you on how to connect several Lego blocks together in order to build a structure. Well, we can take that same concept into CQL, where we have the clinical specifications as the directions to build definitions. And each of those definitions are like Legos or building blocks, where we use one to build upon another until we have a complete definition. So looking at the diagram, the definition we're building is the initial population, which is defined as C. Now remember, each block represents a definition, and each definition has a name and logic to represent a population criteria. So in block A, this is looking for a specific encounter type. So for example, either an inpatient encounter or maybe an emergency room encounter. You'll also want to note that A is the largest block to represent the largest patient population. So the idea is, as we start building the population criteria, we want to start narrowing down the scope of patients. So now in block B, rather than repeating the encounter logic again, we can simply pull definition A into the logic and then add the next criteria we're looking for, in this case, a diagnosis. This is how we connect the definitions together, by nesting one into another. So then definition B now includes the encounter type and the diagnosis. We need one more block to complete the structure, which is an age block. So we follow that same pattern where we connect B with age to create C. Hopefully you see how we build off of the previous definition so that each successive definition helps to constrain the logic. So now in C, we have all the criteria we've defined, the encounter type, the diagnosis, and the age of the patient, and that's how C becomes the initial patient population. On slide 17, we will look at this concept in more concrete terms. We have three definitions to build the initial population. At the bottom of your screen, we'll start with TJC.non-elective inpatient encounter. It's looking for an inpatient encounter. Then in the next block, TJC.all-stroke encounter, notice how it starts with the previous definition name. We then add diagnosis criteria. And then in the next block of encounter with principal diagnosis and age, we start with the previous definition and then add age criteria. So then finally, encounter with principal diagnosis and age is directly used as the initial population. So as you can see, using this methodology of building blocks makes it cleaner to read and allows us to reuse the definitions throughout the measure specifications. Now, there are a lot more terms used in CQL, but these are just some of the basics. So as I mentioned, CQL uses definitions, and all definitions have a name. And that name should encompass the meat of the definition and should be unique, so we can identify it within a library. Libraries are created at the measure level, so each measure builds its own library of definitions as they are written. But we also have global libraries that can be shared across all measures, which is the purpose of creating a library, so we can easily share definitions rather than reinventing the wheel each time. So to identify if the definition is coming from a library, we have a library alias. So if you look at the yellow highlight, a library alias is denoted as a prefix in the name of a definition, in this example, TJC. Some definitions may come from a specific library, so you will not see that denotation. Next, we have the expression. An expression refers to the content of the definition. We use this term a lot when referring to the logic. Looking at a basic construct of an expression, expressions use data types. Data types describe a part of the clinical care process, which refers to a specific category in QDM. For instance, the encounter performed data type is in the encounter category. A medication administered data type belongs to the medication category. Each data type has their own set of attributes. Attributes provide specific details about their data type. So in the example, .relevant period is an attribute of encounter performed, meaning a relevant period defines the start and end time of the encounter. Next, we have a value set, which specifies the kinds of data or codes that we are looking for relative to the QDM category. Ultimately, these are the codes the logic is looking for in the EHR. So in this example, the value set of non-elective inpatient encounter consists of SNOMED codes to satisfy the logic. We would expect to see that any one of those SNOMED codes is present in the patient's record. Lastly, we have an alias. Alias expressions are used to give a source a name so that a bit of logic can be referred to easily within the expression to avoid restating. And on slide 20, just briefly, there is a terminology section in the Human-Readable where you can see all the value sets and direct reference codes used in the measure. The Value Set Authority Center is where you would go to verify these codes. Each value set has a unique object identifier referred to as the OID number to make it easier to research. One of the most common questions we get is, what does union mean? Union is a CQL operator that combines two or more lists together. So in the diagram, any element in list A or list B will satisfy the condition, so anything in the red. From this, you can understand why we've related union to the meaning or, because anything from A or B will meet. And just to clarify what lists are the results of what the logic is looking for in the EHR. Let's look at the example given. The logic is looking for a diagnosis code of either perforation of uterus or uterine window or uterine rupture or ectopic pregnancy. So what union does is it combines all the diagnosis codes into one list so that if the patient encounter has any of the diagnosis codes, it will satisfy the condition. Intersect is another common operator in CQL, which is only looking for the common elements between list A and list B. So the red depicts the shared elements between the two lists. To add some context, let's look at an example. If list A returns a list of all inpatient encounters with age 18 years and older, and list B returns a list of all encounters with a CBC level, then the result of this intersection is a list of inpatient encounters with age 18 years and older and a CBC level. Okay, so that wraps up our CQL 101 crash course. On slide 23, we transition back to CAC-3 version 6. The version is important to note since it will be the version used for the reporting year beginning January 1st, 2019. The initial population reads pediatric asthma inpatients ages 2 through 17 years and length of stay less than or equal to 120 days that ends during the measurement period. The highest level definition for inpatient population is encounter with principal diagnosis of asthma with age between 2 and 17 years. Let's dissect this definition. 3 conditions must be met in order to be included in this definition. The patient must meet all requirements in the global inpatient encounter definition. More on this in a few minutes. The alias name is highlighted in blue and serves as a label so that the list of patients identified in this clause may be referenced later. Throughout this presentation, we will be using blue highlighting to indicate the names, the alias names. Secondly, for the patients identified in the previous logic, the patient must be between the ages of 2 and 17 years at the start of the relevant period, which is the admission date for this measure. The patient's birth date is compared to the start of the relevant period by a function called calendar age in years at to calculate the patient's age. The global prefix indicates that this function is called from the global library. And third, the patient has a principal diagnosis in the asthma value set. Principal diagnosis is an attribute of the encounter performed data type. Now on slide 28, let's dive deeper into the global inpatient encounter definition. This definition can be found in the global library. 3 conditions must be met in order to be included in this definition. First, the encounter must be an inpatient encounter with one of the codes listed in the encounter inpatient value set. There are 3 codes in this value set that are described as emergency hospital admission, elective hospital admission, and just plain hospital admission. Again, the alias name is highlighted in blue and serves as a label so that the list of patients identified in this clause may be referenced later. Second, the length of stay for the inpatient encounter defined on the line above must be less than or equal to 120 days. We use a CQL function called length in days, which calculates the difference between the start and end of a value. And third, the relevant period end date, for example, the discharge date, must be during the measurement period. The measurement period reflects the time period of interest. So now that we've defined all the criteria to meet the initial population, encounter with principal diagnosis of asthma with age between 2 and 17 years becomes a single definition for the initial population. Turning to slide 33, once a patient qualifies for the initial population, we continue moving through the logic to the denominator. The denominator is looking for patients with a discharged disposition of home or home with police custody. Here is the logic for the denominator population. And you'll notice that we reuse the encounter with principal diagnosis of asthma with age between 2 and 17 years from the initial population that we just discussed. In this definition, we are using the alias of asthma age encounter to label this grouping of patients for future reference. In the second piece of logic, we are looking for patients who have a discharged disposition in the value set entitled Discharged to Home or Police Custody. We do this as patients being discharged to other locations, such as another acute care facility or skilled nursing facility, would not be candidates to receive a home management plan of care for their asthma. Discharged disposition is an attribute of the encounter performed data type. On slide 37, you will see our numerator. The numerator includes pediatric asthma inpatients with documentation that they or their caregivers were given a written home management plan of care document that addresses all of the following. 1, arrangements for follow-up care. 2, environmental control and control of other triggers. 3, method and timing of rescue actions. 4, use of controllers. And 5, use of relievers. Or there must be documentation that the patient or their caregiver refused a written home management plan of care document. The home management plan of care document must be present in the form of an explicit and separate document specific to the patient rather than components or segments of the plan spread across discharge instruction sheets, discharge orders, education sheets, or other instruction sheets. Here is this eCQM logic for our numerator statement. You see 2 clauses joined together with a union statement. Remember that union is a CQL operator used to combine 2 or more lists of patients together. On slide 39, you will see a familiar definition being reused from the denominator statement. Encounter with discharged disposition to home or police custody, highlighted in yellow here. Of the encounters with discharged disposition to home or police custody, we are looking for an asthma action plan to be authored or documented during the encounter relevant period, or in other words, between the encounter's admission and discharge dates for this measure. Let's take a closer look at the definition, asthma management plan completed. The asthma management plan completed definition uses the communication from provider to patient data type. This data type represents the transmission, receipt, or acknowledgement of information from a provider to a patient. Asthma Action Plan, highlighted in yellow here, represents a single LOIN code, which translates to Asthma Action Plan. Since we only have one LOIN code to represent this concept, we forego creating a value set and instead embed the LOIN code directly in the logic. So while Asthma Action Plan may look like a value set name, if you refer to the terminology section of the Human-Readable, where all value sets are listed, you will see the actual LOIN code. Turning to slide, and remember, the Asthma Action Plan must be authored during the encounter relevant period. Turning to slide 44, let's turn our attention to the second clause of the union statement of the numerator. Again, the encounter with discharged disposition to home or police custody has been previously discussed. The definition, no asthma management plan due to patient refusal, will be explored next. Here you see we use the same data type, communication from provider to patient, but we add not done and use the negation rationale attribute to capture the concept of patient refusal. Negation rationale indicates the reason that an action was not performed. Only QDM data types that represent actions, for example, performed or recommended, allow the negation rationale attribute. The intent is to provide a justification as to why an expected action did not happen. Patient refusal is a value set consisting of SNOMED codes representing the concept of patient refusal. The value set includes refusal by a patient or a caregiver. The caregiver is defined as the patient's family or any person who will be responsible for care of the patient after discharge. And remember, the negation rationale must be authored during the encounter relevant period. And that takes us to the end of the CAC-3 measure review. Lisa, I'll hand it over to you.
Thank you, Marilyn. We will now take a few minutes to open the session for questions related to the CAC-3 eCQM. To ask a question, please use the questions pane to submit your question along with the slide reference number if possible. We will answer as many questions as time permits before moving on to the next measure presentation. We have a quiet group today. We'll give it just a little bit to make sure no questions come in before moving on, so bear with us. Okay, well, if you do have any questions pertaining to CAC-3, please remember the questions pane will stay open. Oh, here come some questions. So this question comes from, I think, Charla Ogburn from Healthland. And the question reads, on the does must be authored during relevant period, does that mean before the discharge date and time? Marilyn, can you answer that?
Sure, thank you for that question. It means it can be up to and including the discharge date and time, yes.
Thank you. Our next question comes from Edgardo Cosme from Infomedica. Author time, is it relate to? I think that question means, what does the author time mean?
Author time relates to when the home management plan of care was documented in the medical record.
Correct. And just for reference, author date time is an attribute found in the quality data model. So for further information, you can go to the QDM to read the full definition of that attribute. We'll pause just another 30 seconds or so to see if more questions come in the queue. Thank you for the questions so far and for your comments. Those are appreciated. All right, this next question comes from Paulo Andre from MD Interactive. Are there plans to move out from a complex Qrda 3 format to a simpler format? So thank you, Paulo, for your question. Currently, we are using Qrda files to report electronic clinical quality measures, but we are on the move to FHIR. If you haven't heard of that, it's the Fast Healthcare Interoperability Resources. And so that's the move that we're going to, and there's actually a lot of work getting done as we speak, looking for a better way to exchange quality data in the future. Yep, and just to clarify, Qrda 3 files are used by the physicians. For our hospital-based measures, we actually use the Qrda Category 1 file format. Okay, well, thank you. If you do have more questions, please go ahead and put those in the queue, and we can get to them at the end if we have time. We will also get to them in a Q&A document if they don't get answered on the live webinar today, and will be posted on our Pioneers in Quality portal. I would like to now turn it over to Zhidong and Lynn to talk about the EHDI-1a measure. Take it away, ladies.
Right, thank you, Lisa. Hello, everybody. This is Xidong Deng. I'm a health scientist at the Early Hearing Detection and Intervention Program at the National Center on Birth Defect and Developmental Disabilities with the Centers for Disease Control and Prevention. Lynn and I are going to talk about the EHDI-1a measure, which is the hearing screening prior to hospital discharge. Just a little bit background about the EHDI program and this measure. The goal of the national and state-based EHDI program is to maximize linguistic competence and literacy development for children who are deaf or hard of hearing. The Joint Committee on Infant Hearing, or JCIH, is a joint committee consisting of hearing health professionals whose mission is to address issues that are important to the early identification, intervention, and the follow-up care of infants and young children with hearing loss. They have supported the concept of regular measurements of performance and recommend routine monitoring of these measures and continuous quality improvement. So one of these measures that was recommended by JCIH in their 2007 position statement was hearing screening prior to hospital discharge. In 2012, CDC EHDI program developed the EHDI-1a measure based on this recommendation and was subsequently endorsed by the National Quality Forum and then adopted by CMS and the Joint Commission. CDC remains to be the steward of the original EHDI-1a measure and works with the Joint Commission on its implementation, which Lynn will talk about next in more detail. So, Lynn?
Thank you, Shidong. So now we're going to go over the population criteria for the EHDI-1a measure. And the initial population narrative reads, live birth encounters at a hospital or birthing facility where the newborn was discharged with hospital stays less than or equal to 120 days that ends during the measurement period. The dark blue box on this screen shows that the initial population uses two blocks of logic: encounter with live birth diagnosis and diagnosis live birth newborn born in hospital. The two blocks of logic and value set that are used to create the encounter with live birth diagnosis logic are shown below the dark blue box. So let's dig into each of these blocks of logic a bit further. On slide 51 here, you can see we have the inpatient encounters defined statement that is used to build both definitions of the of the initial population, the encounter with live birth diagnosis, and the diagnosis live birth newborn born in hospital. Starting with the first line of logic, the encounter performed data type is used to define the inpatient encounter. For this measure, a patient must have one of the encounter codes listed in the encounter inpatient value set. Following the brackets is the alias name encounter. The alias is used to reference elements or primary source in subsequent clauses or pieces of logic. Supplemental timing attributes, such as prevalence period and relevant period, were added to most QDM data types to facilitate accurate retrieval of time-related information within the CQL logic. The relevant period attribute addresses the time between the start of an action to the end of an action. Each data type using relevant period is constraining or assessing the logic to the start and stop time for the event listed. In this case, the start and stop time of the inpatient encounter. You can see on the last line here, we use the relevant period of the encounter to determine if the encounter occurred during the measurement period. We're now on slide 52, and on the second line of logic, you see that global precedes length in days. And this is because this function is located in the Measure Authoring Tools Global Common Functions library instead of the Measure library, and is referred to as a global function. Using the Global Common Library helps maintain consistency across measure specifications when measures are assessing the same thing, like length in days of an encounter. The alias global is used to pull the logic from the Measure Authoring Tool Global Common Functions library. To determine if the encounter is within the 120-day parameter, we use the CQL function length in days to calculate the difference in days between the start and end date of the encounter relevant period, also known as value. The global length in days expression is shown here in the gold-colored box. With this definition statement, the logic assesses if the patient had an inpatient encounter, and if so, was that encounter less than or equal to 120 days, and did it end during the measurement period? So on slide 53, we move on to the encounter with live birth diagnosis defined statement. And we pull in the inpatient encounters definition statement that we just discussed and give it the alias inpatient encounter as highlighted here in yellow. On slide 54, the second line of logic starts with where exists. The where clause allows filtering of a result to only the information that meets the condition. For this measure, we only want the inpatient encounters that have a diagnosis of a live birth newborn born in a hospital. The exists operator works on a list of values and returns true if the list has any values or false if the list is empty. So putting this line of logic together, the measure compiles a list of inpatient encounters and assesses diagnosis codes during those encounters using the alias encounter diagnosis as shown here in yellow. So on slide 55, continuing down to the third line, the logic is looking for an encounter diagnosis within the live birth newborn born in hospital value set. The live birth newborn born in hospital grouping value set includes ICD-10-CM and SNOMED CT codes that represent diagnoses that are commonly used in the inpatient setting for newborns born in the hospital facility who have an active diagnosis of live birth. The measure does not require an age calculation because the diagnosis codes refine the population to only those encounters with a live birth diagnosis. The live birth newborn born in hospital value set was updated in version 6 of the measure for the 2018 reporting year to better capture the correct population because encounters for the mother were inadvertently pulling into the population due to mapping issues. So effective with version 6 and later, codes in this value set map only to the infant. So we're now on slide 56, and unfortunately I put the value set on this slide instead of the diagnosis live birth newborn born in hospital definition statement. Please accept my apologies for that, but I'll do my best to walk you through that definition verbally. So the definition for diagnosis live birth newborn born in hospital reads inpatient encounters with an alias of inpatient encounter. And then the next line reads with diagnosis live birth newborn born in hospital with an alias of qualifying diagnosis. The next line of logic in that definition reads such that qualifying diagnosis dot prevalence period starts during inpatient encounter dot relevant period. So to build this definition, the inpatient encounters logic is pulled in and given the alias inpatient encounter. The with keyword is used to describe cases that should only be considered if a related data item is present. In this case, a diagnosis from the live birth newborn born in hospital value set, which we've given the alias qualifying diagnosis. And the prevalence period, or the onset and abatement times for the qualifying diagnosis, must start during the relevant period of the inpatient encounter. So looking at the dark blue box, the initial population logic is built with the two definition statements we just defined, the encounter with live birth diagnosis and the diagnosis live birth newborn born in hospital. The union operator between these two definition statements means or, so either definition will meet the initial population criteria. A common question we receive on the measure's initial population is, if a baby is born at Hospital A and then transfers to Hospital B for a higher level of care, is that baby in the initial population for both hospitals? And the answer is that the intent of the measure is to assess the number of live births at a facility that have been screened for hearing loss before hospital discharge. So in this scenario, when the baby is born at Hospital A and then transfers to Hospital B for a higher level of care, the baby would be included in the initial population for Hospital A, but would not be included in the initial population for Hospital B, since the baby was not born at Hospital B. Hospital A could claim the exclusion for the diagnostic hearing screening not done due to medical reasons or contraindications, and we'll cover that exclusion criteria later in the numerator logic. On slide 57, once the patient qualifies for the initial population, the process moves to the denominator. For this measure, the denominator is equal to the initial population as shown here in the dark blue box. So on slide 58, we effectively carry all the definitions used to build the initial population into the denominator. As you can see in the gold-colored box, the definition statements we just discussed for the initial population are reused here in the denominator. Those are encounter with live birth diagnosis, inpatient encounters, and again, I see here that I inadvertently put in the value set rather than the diagnosis live birth newborn, born in hospital definition statement that we just discussed. On slide 59, an exclusion to the denominator is a live birth encounter where the newborn expires prior to discharge and has not received a complete hearing screening. A complete hearing screening is defined as having both ears screened during the inpatient encounter. So here on slide 60, like with the denominator, we begin building the denominator exclusions logic by pulling in the definitions from the initial population and give it the alias live birth encounter. Here on slide 61, we look at the discharged disposition, specifically looking to see if there is a status of dead during the live birth encounter. You may notice in this version that we replaced the discharge status attribute with the discharge distribution attribute for the encounter performed data type to align with QDM version 5.3 changes. Here we use a direct referenced code, meaning that the logic references a single code. In this case, the logic is referencing SNOMED CT code 371828006, which is described as patient deceased during stay, discharge status equals dead, and finding. The squiggly line is called a tilde. A tilde is the equivalence operator in CQL, meaning if the live birth encounter discharge disposition is equivalent to the deceased code, it returns true. On slide 62, the final line of the denominator exclusions logic states, and not exists, has complete hearing screening. The has complete hearing screening block of logic is shown here at the bottom of the screen, so let's break that down a bit further. Here on slide 63, to build the has complete hearing screening definition, we begin by reusing the inpatient encounters definition. And on on slide 64, from that pool of encounters, the logic assesses if a left hearing screen was performed, seen here in yellow highlighting. But before we go further, we need to define what left hearing screen performed means. If you look just below the dark blue box, you can see the left hearing screen performed definition statement. The diagnostic study performed data type is used to document completion of the diagnostic study indicated by the QDM category and its corresponding value set. Here we're looking to see if a hearing screen of the left ear was performed by identifying LOINC codes from the newborn hearing screen left value set, where the result of the left hearing screen was a code from the pass or refer value set. The pass or refer value set is comprised of SNOMED CT codes that represent findings that indicate either normal findings on the hearing examination or that a referral is needed. So going back to the has complete hearing screening definition statement, we pull in the left hearing screen performed definition statement and give it the alias left hearing screen. The third line assesses those inpatient encounters where a left hearing screen was performed and the author date time for the hearing screen was during the inpatient encounter relevant period. On line 65, we'll take a look at the right hearing screen performed. And the right hearing screen performed definition is built just like the left hearing screen performed definition and looks for a result within the pass or refer value set and author date time during the inpatient encounter relevant period. Note the use of the and exists operators here. That means that both the left and right hearing screens must be performed with a result of either pass or refer to meet the has complete hearing screening criteria. So putting the denominator exclusions building blocks together, an exclusion would be met if there is a live birth encounter where the newborn expires prior to discharge and has not received a complete hearing screening. On slide 66, we'll move on to the numerator. And the logic is looking for a live birth encounter where either a complete newborn hearing screening is performed prior to discharge or the newborn is not screened due to medical reasons. The numerator is built with two definition statements, has complete hearing screening and hearing screening not done due to medical reasons. The has complete hearing screening definition, shown here on slide 67, we discussed in the denominator exclusions, and we've reused it here in the numerator. So here on slide 68, the has complete hearing screening definition unions the hearing screen not done due to medical reasons definition. To build the hearing screen not done due to medical reasons definition, we start by pulling in the initial population definition and reusing the alias live birth encounter as shown in the orange-colored box. We're now on slide 69, and using the live birth encounter, we then determine if a hearing screen was not done in either the left or the right ear. To do this, we use the diagnostic study data type with the negation rationale attribute. You might recall from Maryland that the negation rationale indicates a reason that an action was not performed, and only QDM data types that represent actions, such as performed, allow the negation rationale attribute. The intent is to indicate a justification that such action did not happen as expected. If this produces a result, meaning at least one ear was not screened, then the logic looks to see if there's a medical reason why it was not done using codes from the medical reasons value set. The medical reasons value set includes SNOMED CT codes to capture medical contraindications, surgical contraindications, and not indicated because there's a reason to withhold a certain medical procedure or treatment because it could harm a patient, or if the infant needs a transfer out because he or she is critically ill. A comprehensive list of codes for these conditions is not available because the judgment's often subjective. This value set is not intended to be used for other reasons the screening was not performed, such as parent refusal, technical failure, or a missed procedure. We use the author date time attribute to capture the time the data element was entered into the clinical software because we've heard from implementers that it's difficult to know the start and stop times for hearing screenings. The reason for using author date time here rather than relevant period is because relevant period requires both a start and stop time. So therefore, the author date time attribute is used in this measure because the start and stop times for hearing screenings are not always known. As previously stated, the union operator here means or, so either will meet the criteria. So putting that all together, encounters at a hospital or birthing facility where the live-born newborn was discharged within 120 days or less and that end during the measurement period, and who received a complete hearing screen, meaning both ears were screened, or did not receive a complete hearing screen because of a valid medical reason. So some common questions that we receive regarding medical reasons include, does documentation of medical surgical contraindication have to specify laterality, such as left ear or right ear, to pass the measure? Because numerator guidance suggests that both left and right are to be addressed. And the answer is that the intent of the measure is to capture complete infant hearing screens defined as having both ears screened during the inpatient encounter. The measure determines if a hearing screen was done for both the right ear and the left ear. And for each ear, it assesses a result of either pass or refer, or if the screen was not done due to medical reasons. Another frequent question that we get on this measure is that in the event that a repeat hearing screen is performed, should only the initial screen result be submitted, or would it be appropriate to include the most recent screening result? And the answer to that is that the measure does not specify initial or most recent for the hearing loss screening result, only that the screening is performed prior to hospital discharge. On slide 70, you can see that this measure does not have numerator exclusions or denominator exceptions. And that concludes the EHDI-1a measure overview. Thank you for your attention, and I'll turn the discussion back to Lisa now.
Great, thank you, Lynn. Before we move into the Q&A portion, we'll do a quick review of some of the key resources The eCQI Resource Center is a one-stop shop for eCQM-related information. It houses the various tools and resources such as the measure specification, the technical release notes, which describe all the changes made during annual updates and the addendum. There are measure flows to help understand how the data is processed, links to the QDM or the Quality Data Model and CQL standards, as well as previously recorded webinars and slide presentations. There is also an event calendar where you can find additional educational sessions. The Value Set Authority Center is where we store all the value sets and direct reference codes used in the measures. It does require a license, but it is free to the public. Here in number 3, we are frequently asked about how to implement CQL. There happens to be a presentation from HIMSS from 2018 titled Getting Started with CQL, Technical Implementation for Vendors, that provides an overview of the CQL architecture, building a CQL execution engine, and using open source execution engines. A newer version presented at HIMSS this year will be available soon, so more details to come. Items 4 and 5 are quick links that will take you to the JIRA site to submit questions or comments specific to CQL or the eCQM measures. And lastly, in 6 and 7 are the links to the Pioneers in Quality portal, where you can find all previously recorded presentations and slides and register for the upcoming educational sessions. We will now move into the final question and answer segment of the session. To ask a question, please type your question and the slide reference for number in the questions pane. We will answer as many questions in the remaining time. All questions submitted will be addressed in a follow-up Q&A document and posted on the Pioneers in Quality portal. And this first question comes from Lori at EE Health. The initial population hearing screening. If a baby born in Hospital A and then transferred to Hospital B, then the baby should only be included for Hospital A and not included for Hospital B. Is that correct? Lynn, I heard you talk about this in your presentation, but can you answer that question for us?
Happy to. Yes, that is correct. Hospital A only.
Great, thank you. This next question comes from Patricia Fryer from Covenant Health. Why isn't either of these denominator exclusion? A, newborns who were admitted to the NICU, or B, transferred to an acute care facility? Lynn?
Thank you, Lisa. So for that, newborns admitted to the NICU, again, just recall that the intent of the measure is that the hearing screen be done before discharge. So we would assume that if they were transferred to a NICU, at some point they would be discharged. So looking for a hearing screen done before that discharge. And in scenario B, they're transferred to an acute care facility. That's like the example that I gave during the presentation. If they're transferred to an acute care facility for a higher level of care, you can use that medical reasons exclusion.
Thank you. Our next question comes from Maureen Disbot from St. Joseph Health. Who is qualified to do a hearing screen in an acute care hospital? And that question's for Lynn.
Hi, this is Lynn. The measure doesn't define who can perform a hearing screen, so we would leave that to the discretion of the facility. Jadong, do you have anything you would want to add to that?
No, I think your answer is correct because the measure doesn't define who does the hearing screening.
Thank you. Our next question comes from Susan Spencer. The reasons for not performing the test are to be added into discrete fields like nursing flow sheets, and is there a specific script that needs to be documented?
Hi, this is Lynn. Can I research that question and respond to that in the the Q&A document that we post afterwards?
Great, thank you.
Thank you.
Our next question comes from Ivy Villanova, who is a student, and she's referencing slide 51. Is this only exclusive for a routine test? How about inpatient follow-ups for problems seen during the initial screen?
So this would be for hearing tests done at the time, at the encounter where the baby was born. So inpatient follow-ups, if those were subsequent encounters, would not be included.
Thank you. Our next question comes from Paulo Andre from MD Interactive. Can we expect the transition from Qrda format to FHIR format to occur in 2020 or 2021? Thank you, Paulo. So I can definitively answer you that we will not be seeing a replacement for Qrda for the 2020 reporting period. I don't want to assume about 2021, but again, that work is getting done in the HL7 community, so if you're interested in that, reach out to us and we can help you connect you with those stakeholder groups so you can be informed and be an informer to all of that work. And that wraps up the questions that are in our queue. I will give another few seconds if anyone has any final question for either the CAC-3 or the EHDI measure.
Lisa, this is Lynn. So for that question that I had asked to be deferred, we would use the discrete field should be used, and there is no specific script.
Great, thank you. I think that was referring back to the negation rationale for the reason why the test wasn't performed. So thank you for clarifying that.
Yeah, thank you.
Okay, I don't see any more questions coming into the queue. A few closing remarks before we end this session. As a reminder, the slides are available for download now. Please visit the Expert to Expert Series landing page, which includes the registration links for future sessions, presentation replays, slide decks, and Q&As. Our next session addresses PCO1 and PCO5. Please register and join us on March 26th. On February 25th, the Joint Commission launched the 2019 Proven Practices Submission Tool. This is your chance to receive Joint Commission recognition for your eCQM proven practices. Submitters that earn expert contributor distinction are invited to present on webinars and are featured within the Proven Practices collection. Visit the link on this slide for additional information and to access the link to the online submission tool. If you qualify for CE credits, please complete the survey you can access via the link in an automated email. I'm sorry, I'm going to start over on that. If you qualify for CE credits, please complete the survey that you can access via the link in an automated email you will receive tomorrow. The evaluation closes 2 weeks from today. Once the survey closes, all those that complete the survey and are eligible for CEs will receive an email with a PDF certificate. Thank you to everyone who took the time to present at today's webinar, and thanks to all of you who listened in. Have a good day.